this is where we don't have definite answers yet. So if you look at the two top curves, the combination in the orange and the nivolumab monotherapy in the blue, both of those curves are doing better than ipilimumab alone, which we have established. But in between the two curves, the overall survival, there may be small differences, but definitely not home run for one or the other. There has been a lot of talk about using PD-L1 expression levels to choose the combo versus monotherapy, and the suggestion has been that patients who have high PD-L1 expression, maybe you don't gain as much from the combination, but patients with low PD-L1 expression, maybe combination may lead to better outcomes. But this is again subset analysis, smaller number of patients, and I don't think this test should be used in the clinical setting for this determination. I think we need to establish the proof a bit more rigorously. So my conclusions on these results are that at this time there is no significant survival benefit to ipi-nivo and nivo alone. The subset analyses, they warrant further confirmation in future studies. But the trial is still telling us a lot. We are getting greater immune stimulation with the combination, so there is something to pursue with the combination here. And right now what I do is I discuss this data with all the patients and then make an individualized decision based on patient tolerance of side effects and a desire for aggressive therapy. But it also gives us an opportunity that the high rate of toxicity obviously is a big deterrent, and maybe we can use this proof of concept with greater immune stimulation and work out the regimen a little bit more, where we are still getting the desired immune stimulation, but maybe not at the cost of such high rate of toxicity. And fortunately, there are efforts going on in that arena. So there are several trials now which are using lower dose ipilimumab at 1 milligram per kilogram instead of 3 milligram per kilogram, and that does lower down the rate of toxicity. And there are head-to-head trials of the two regimens which have been completed, and the results should be available soon. The other, instead of the dose, the other way to reduce exposure will be reducing the frequency, and some trials are actually using both strategies, using a lower dose of ipi at 1 milligram per kilogram, but also using a lower frequency, instead of every 3 weeks, reduce it to every 6 weeks or so. Then also, we need to prioritize research on frontline studies of less toxic combinations. And this is my slide from last year at this conference, where I had proposed that IDO inhibitor plus PD-1 might be one such combination. After a long time, we have been spoiled in melanoma in having successful trials one after another that get published in New England Journal. But this was a reminder of how life used to be 10 years back, 15 years back. And as you can see, these two curves, you don't need to know which color is which arm. It doesn't matter. But this is IDO inhibitor plus Pembro versus Pembro alone, and there was no benefit whatsoever. And this was a big phase 3 trial, and there was a lot of excitement about IDO inhibitors. I don't think they are dead yet, but the enthusiasm has been considerably dampened because of this result. So the second question was, is it safe to stop therapy in a responding patient? And fortunately, we have some reassuring data. So this is a trial that was reported at the ASCO meeting this year. This is looking at long-term outcomes in patients who have benefited from pembrolizumab, and then they stopped it either because of toxicity or because they completed the protocol-specified duration of treatment at 2 years. And so this trial had around 100 or so patients who had good responses. They had benefited from pembrolizumab, and then they completed the protocol-specified therapy, and then stopped it, and then we had follow-up on these patients to see what happens once once you stop pembrolizumab. And as you can see, the vast majority of patients, they continue to have the benefit sustained for several months after they stop pembrolizumab. Patients who had complete responses, the vast majority of those were progression-free, so 96% were progression-free at 18 months. Patients who had partial responses, again, more than 90% of patients did not develop progression. And patients who had stable disease, there was a higher proportion of patients who had progressed. But then the reassuring thing was that out of these patients who progressed, if they were re-challenged with pembrolizumab, the benefit was recapitulated with the reinduction therapy. The vast majority of patients, again, had responses reinduced, whether partial or complete or stable disease, which is, again, reassuring. So one thing I think which we are recognizing now more and more of is these agents are not harmless. It is true that majority of the toxicity happens in the first few weeks, but even with long-term administration, we are now seeing some immune-related adverse events that happen 2-3 years into the treatment. So I think prolonged exposure does have its own risks, and this kind of data is more reassuring that it's probably okay to stop therapy at some point in patients who are doing really well, follow them closely, and the options for immunotherapy will still be relevant if they were to progress. But this way you can really minimize exposure to the whole group of patients who seem to be benefiting. So third question, what to do in PD-1 refractory patients? As you probably know, there are hundreds of trials going on in this setting. Most of these trials are using the backbone of anti-PD-1. There are a few that are using IPI as the backbone, and then they're adding their drug of choice to that backbone. And there is a lot of promising data, preliminary data, which I don't have time to go over. But there was one study presented at ASCO, which I think is relevant to how we treat patients. So this study looked at, in a more rigorous way than what we have been doing in clinic, patients who had only had PD-1 monotherapy. Once they progressed on PD-1 monotherapy, their disease was refractory, declared refractory to the PD-1. These patients got ipilimumab added to the PD-1 regimen at that time. And the PD-1 agent of choice in this one was pembrolizumab at the standard dose given every 3 weeks. And ipilimumab was added at the dose of 1 milligram per kilogram for a total of 4 doses, again every 3 weeks. So the rationale for the low dose was that there has been a frontline study published in PD-1 naive metastatic melanoma with this combination. The response rate was fairly high, 57%, very similar to nivolumab plus ipilimumab at the higher dose, but the rate of toxicity was lower as compared to more 60%. This was more like 40% or so. So somewhere between IPI and the full dose IPI plus PD-1 combination. So this is the data from this trial. The response rate actually was fairly high, the best we have seen in PD-1 refractory patients in most of the trials. Now again, this was a small study with only 22 patients, but they noticed 10 patients who had objective responses, and these responses happened regardless of elevated LDH or whether the patients have visceral metastases. The toxicity was actually quite favorable. The rate of grade 3 higher adverse events was only 16%. Which is much lower than the combination of nivo plus ipi at 3. But there is obviously a reason. These are patients who are selected for not having predisposition to an autoimmune condition because they have already been on PD-1 agents. And one of the entry criteria for this trial was that they must not have had a serious toxicity on PD-1. So you're selecting for patients who are less likely to have immune side effects. But nevertheless, it's reassuring that IPI at 1 mg per kg, when added after the progression on PD-1, can possibly salvage some of these patients. So this is something that we can do in the clinic now. Last but not the least, there has been a lot of development in the adjuvant field, and I will probably only be able to touch on it briefly. So as you know, that high risk or even earlier stages of melanoma can be fairly high risk for recurrence. On the left-hand side, you see localized melanomas, stage 1 and 2, and you can see stages 2B and 2C, they have close to a 50% chance of recurrence, highlighting that the disease is systemic and we need systemic adjuvant therapy. For 3B and 3C, the prognosis is much worse, and this is where we have most of the data that exists right now. So as you know, high dose of ipilimumab at 10 milligram per kilogram was approved in 2015, and this was the indication on the package. And the data for that was published in the New England Journal, and this was probably this was the first convincing article that showed that immunotherapy can actually improve survival in earlier stages of melanoma. And you can see some benefit in